Good evening. I am today we'll be discussing on the newer terminologies in epilepsy. As we know that every year there's been new terminologies that have been introduced by the International League Against Epilepsy, not only in the field of neurology but in all the fields. There is a constant change in the terminologies of various epilepsy syndromes as well as various other etiologies. So today we'll be discussing the newer terminologies in epilepsy. So first, we discuss about what is an epilepsy syndrome, what is the newer definition of epilepsy syndromes. Then we'll be discussing the various epilepsy syndromes in the neonatal, childhood, and adolescent age group, and what are the various studies on this. So, what is an epilepsy syndrome? Epilepsy syndrome is a cluster of features which incorporates the typical clinical seizure type, the typical EEG imaging features that tend to occur together, which usually have a age-dependent onset and offset, which have particular seizure triggers, diurnal variation, and distinct comorbidities, such as intellectual and psychiatric dysfunction, often supported by specific etiological findings, which could be structural, genetic, metabolic, immune, and infectious, and frequently they carry a prognostic and treatment implication. So, what is epilepsy? Epilepsy is two or more unprovoked seizures occurring more than 24 hours apart, or a single seizure with an increased risk of developing future epilepsy more than that of general population. So an epilepsy syndrome, on the other hand, is a clinico-electrographic definition, which is an age-dependent onset and offset of seizures, a specific seizure type or multiple different seizure types that may be present in in a single syndrome and may be associated with certain comorbidities like ID, ASD, and may have certain etiological factors like certain channel mutations or certain neuroimaging abnormalities. So these are a distinctive clinical electrophysiological syndrome. So epilepsy, as we know, is age dependent. Certain epilepsy syndromes come in the neonatal age group, some come in the childhood, and some in the adolescent. The highest incidence is less than 5 years, and it's bimodal. The other incidence is beyond the 65 years of age. The higher incidence of epilepsy is seen in the first year of life than in older children. But these population-based studies are more from high-resource countries, whereas in resource-limited countries, the acquired epilepsies, that is more of in post-infectious and post-autoimmune encephalitis, are more common etiologies of epilepsies. So the International League Against Epilepsy has given specific terminologies for each epilepsy syndrome. It has given three kinds of criteria for each syndrome. One is a mandatory criteria, second is the exclusionary criteria, and third is the alerts, along with typical features of both clinical, electrophysiological, neuroimaging, and prognostic factors for each syndrome. Based on the seizure type, the syndromes are characterized as focal and generalized, with a specific category known as DEE, which is developmental and epileptic encephalopathy. Also, additionally, it has also given a few other terminologies like syndrome in evolution, that is early epilepsy cases, which may take time to develop the other specific characteristics. Then it's also given certain terminology like etiology specific epilepsy syndrome, where an underlying genetic etiology is known. This is important because in the era of genetic medicine, now we have more access to genome sequencing, and more genetic causes of epilepsies are coming out, and they have a good prognostic significance in the form of a precision medicine tools available. There are certain medications which work on specific channels, and knowing this helps us in a precision medicine of that epilepsy syndrome. Then it is also given a terminology of syndrome without lab confirmation, where there is paucity of resources, that is EEG imaging is not available. Still, we can diagnose epilepsy syndromes based on the clinical data. So these are three things which are being given for each epilepsy syndromes. One are the set of mandatory criteria. These are the criteria which must be present in order to diagnose the syndrome. If a single mandatory criterion is absent, that syndrome cannot be diagnosed. So these should be present for the diagnosis of a syndrome. The second are the alerts. Alerts are the criteria which are usually absent in the majority of those syndromic cases, but rarely can be seen. Alerts alone in a child would not exclude the syndromes, but should cause the clinician to think about the diagnosis and undertake further investigations. And more the number of alerts, less confident than one should be in making the diagnosis of a syndrome. So these are rare features that may be present in a syndrome. So more the alerts, less likely is the syndrome. And for mandatory, all the criteria must be present to make the diagnosis of a syndrome. In the third set of criteria, exclusionary criteria. These, if are present in that case, that syndrome is excluded. That is, this is never found in that syndrome. So we start with the epilepsy syndromes which have onset in the neonatal and infantile age group. As you all know that neonatal seizures are mostly acute symptomatic seizures, mostly specific to a certain etiology like hypoxic ischemic injury, electrolyte abnormalities, intracranial bleed, stroke, brain malformations. These are all acute symptomatic etiologies. But rarely, we may also have neonatal onset electrocognitive syndromes, which were previously known as Otara syndrome or early myoclonic encephalopathy, which are rare as compared to the acute neonatal seizures. Importance of identifying these electroclinical syndromes is, as these are usually longer in duration. These symptomatic seizures are usually uh, they go beyond a certain age. They do not require long-term anti-seizure medications. You can stop anti-seizure medications even at discharge or within 1 to 3 months, whereas the electroclinical syndromes will require a longer anti-seizure medication and may or may not be associated with comorbidities like developmental delay, intellectual disability, and behavioral abnormalities. So it has neonatal onset and infantile onset epilepsy syndromes have divided into three parts. The first is the self-limited epilepsy syndromes. These are previously known as benign epilepsy syndromes. The term benign has been removed as all the benign syndromes do not have a similar prognosis. Some of them may have some amount of delayed development, intellectual disability. So self-limited indicates that these are usually pharmacoresponsive and usually abort by a certain age, but they may not be completely benign. They may have associated comorbidities as well. The second syndrome is the developmental and epileptic encephalopathies or DEE. This terminology indicates that the developmental impairment in this syndrome is related both to the underlying etiology as well as the epileptiform abnormality. Whereas in an epileptic encephalopathy, the developmental impairment is related to the epileptic discharges. Once we treat the epilepsy, the seizures are controlled, the development proceeds in a normal fashion. Whereas in a DEE, even if we control the epilepsy, the underlying genetic abnormality causes developmental delay. And despite the epilepsy being controlled on the number of drugs, the child may continue to have developmental concerns. The third category it has mentioned in neonatal and infantile epilepsy syndromes is etiology specific syndromes, which we discussed are molecular targeted syndromes, which we have a molecular diagnosis, which helps in deciding precision medicine drugs. So these are the various neonatal and infantile onset, self-limited epilepsies, etiology-specific syndromes, and DEEs. In self-limited epilepsies, we have the self-limited neonatal epilepsy, self-limited familial neonatal infantile epilepsy, self-limited infantile epilepsy, generalized epilepsy with febrile seizure plus or Jeff's plus, and myoclonic epilepsy in infancy. For the DEEs, we have a broad group of early infantile, developmental, and epileptic encephalopathy. We have epilepsy in infancy with migrating focal seizures, the infantile epileptic spasm syndrome, which was previously called West syndrome, and the Dravet syndrome. These are the neonatal and infantile onset epilepsy syndromes. Then we have the etiology specific syndromes, which include KCNQ2-DE, pyridoxine dependent DE, pyridoxamine 5-phosphate deficiency DE, CDKL5, PCDH19, GLUT1 deficiency syndrome, Sturge-Weber, and gelastic seizures with hypothalamic hamartoma. So, for example, this is the most common self-limited neonatal epilepsy, which is called the self-limited neonatal epilepsy. Previously, it is caused by multiple names like fifth day fits, benign neonatal seizures, benign idiopathic neonatal convulsions. It has a certain set of criteria that the pregnancy should be uneventful. It should be a full-term gestation, appropriate for gestational age. Your GAR score should be more than 7. Usually starts around 4 to 6 days after the birth. That is why it was previously called as fifth day fits. The child has a normal neurological examination both before the onset of seizures and even after the onset of seizures. All the basic lab parameters and electro EEG and MRI are all normal, and there is no family history of neonatal epilepsy. So these are the seizures which are predominantly focal tonic in nature, affect the head, face, and trunk, and they alternate from side to side. The good thing is that these are usually self-abortive, they are pharmacoresponsive, and beyond 3 to 6 months of age, they themselves abort. Similarly, you have self-limited familial neonatal infantile epilepsy. Here, there's a family history of uh, seizures in the neonatal age group. The onset has been 1 day to 23 months of life. It also has focal tonic seizures, which may evolve from side to side. But the important thing is there's a family history involved. Then we have another a self-limited familial infantile epilepsy. Here also there are seizures which involve the head, trunk with eye movements, which may move from side to side. This important thing here is there are mutations in the channels, the sodium channels, PRRT2, SCN2A, KCNQ2. So as we see, we have certain mandatory criteria, then we have the alert criteria, and then we have the exclusionary criteria. Then there is myoclonic epilepsy in infancy, which are usually started with myoclonic seizures with a normal EEG background. This is also self-limited epilepsy. Then we come to developmental and epileptic encephalopathies. The infants which present with early onset severe epilepsy with developmental comorbidity, which is attributed both to the underlying genetic cause as well as to the uncontrolled epileptic activity, is called as DEE. The DEE, which start within the first 3 months of life, are known as early infantile developmental and epileptic encephalopathy. The criteria for this is mandatory criteria are the T seizures are either tonic seizures and or myoclonic seizures. The EEG is bad. It shows either burst suppression pattern or multifocal discharges with the background showing diffuse slowing. The age of onset is within the first 3 months of life. There is developmental impairment prior to or shortly after the onset of seizures. And the course is abnormal neurodevelopment, including developmental delay and intellectual disability. So these all should be present for the diagnosis of EIDE. If we have normal development at onset, then it is an alert that it is rarely present. It may be present, but it is rarely present. And if you have normal neurological examination, then that is also an alert. Because as we know, EIDE is a bad epilepsy syndrome, usually has developmental impairment and abnormal neurological examination. If it is normal, that is an alert. So previously, infantile onset epileptic encephalopathies were classified as Ohtahara and early myoclonic epilepsy. But because there was a lot of overlap between the two and differentiating the two did not help in the treatment, it was almost the same. So it is now combined into early infantile developmental and epileptic encephalopathy. Then we have epilepsy of infancy with migratory focal seizures. Most important for us is infantile epileptic spasm syndrome. This was previously known as West syndrome. The terminology change has been done because West syndrome was classically a triad of epileptic spasms, hypsarrhythmia on EEG, and developmental stagnation or regression. But in resource limited settings, getting an EEG is difficult and it may take time as well. So, because it takes a lot of time and the treatment gets deferred, and earlier treatment has shown better responses, that is why the terminology of infantile epileptic spasm syndrome was started, in which any one of these criteria may be lacking. So, even if you have developmental delay and regression with epileptic spasms, you can label the child as IESS and start the hormonal treatment. You do not need to wait for a EEG. So the importance and emphasis is on early diagnosis and early installation of steroids in the form of ACTH or oral steroids, because shorter lag time leads to better outcome. So these are the mandatory criteria for IESS. It should have flexor, extensor, or mixed epileptic spasms, which often occur in clusters. The interictal EEG shows hypsarrhythmia, multifocal or focal epileptiform discharges. Also, point to note that hypsarrhythmia is not present in all cases of IESS. There are other variants like modified hypsarrhythmia, which may have burst suppression, which may have focal discharges as well. So, hypsarrhythmia alone as a criteria for diagnosis of West syndrome could lead to missing few cases of West syndrome. Age of onset is usually within the first 2 years of life, and there is developmental slowing after the spasm onset. These are the mandatory criteria. Alerts would be age of onset within the first 2 months, and normal interictal EEG is a point against. It is an alert. Alert is like this present in a few cases, but not in all cases. Whereas exclusionary will be a normal ictal EEG or normal interictal EEG would be a exclusionary criteria. Also, as I told, that ILE is also given certain terminologies like possible evolving syndrome, so as to early identify cases which may develop into the IESS. So possible evolving syndrome are infants with a preceding brain injury, developmental brain malformation of specific genetic conditions, including early infantile DE, who show significant intellectual abnormalities should be watched carefully for the development of epileptic spasms. Like a child with cerebral palsy, that child is also a case of possible evolving syndrome. That is, you should have a very high risk of suspicion that if any abnormal movements like jerks or startles are noticed, you should think of IESS in such a case. Also, we have a terminology of syndrome without laboratory confirmation, like in resource limited settings where an intellectual EEG is not available. Presence of a typical clear history of epileptic spasms, which are witnessed by a clinician with the presence of developmental delay or regression, is enough for the diagnosis of infantile epileptic spasms, even the absence of EEG. Similarly, we have Dravet syndrome. Dravet syndrome, the mandatory criteria are recurrent focal tonic seizures, which may be febrile initially and later on become afebrile, which may also have focal to bilateral tonic-clonic and generalized clonic seizures, onset within 1 to 20 months of age, and usually are drug-resistant epilepsy and associated with intellectual disability. A possible evolving syndrome for Dravet will be a child who is an infant who presents with prolonged focal seizures or bilateral tonic-clonic seizures with fever. Here, the possibility of Dravet should be considered. So every infant who presents with a febrile status, especially if it is focal, less than 12 months of age, should be a high risk for Dravet syndrome. Then the third category was etiology-specific syndromes, which have a particular genetic etiology and which has a precision medicine target available. For example, if you have an SCN2A related DE, if it has a gain of function mutation, we would try sodium channel blockers. Where if it has a loss of function mutation, we should avoid sodium channel blockers. In SCN8A DE, we use high dose phenytoin. In XTX-BP1, we use levetiracetam and phenylbutyrate. In CDKL5, there are two drugs, ganaxolone and fenfluramine. In KCNT1, we use quinidine. In KCNQ2, we use sodium channel blockers, gabapentin and reticabine. In GLUT1 deficiency syndrome, we use ketogenic diet. In pyridoxine-dependent epilepsy, we use lysine-restricted diet with pyridoxine supplementation. And in PCDH19 clustering epilepsy, we use ganaxolone and stiripentol. Unfortunately, few molecules like ganaxolone, stiripentol are not available in our country. These are the various criteria for KCNQ2 related DE, pyridoxine 5-phosphate and pyridoxine dependent DE, and CDKL5 DE. Now we come on to the ILE classification definition of epilepsy syndromes with onset in childhood. Again, these have been divided into three categories. One is the self-limited focal epilepsies. Second are the genetic generalized epilepsies. And third is the developmental and epileptic encephalopathies. Each syndrome has a mandatory seizure type, EEG, age of onset, and key investigations. So these are the various childhood onset epilepsy syndromes. The first one is the self-limited focal epilepsies, which contains 4 syndromes. The first one is SELECTS. It is called self-limited epilepsy with centrotemporal spikes. It was previously known as BSETS or Rolandic epilepsy, that is childhood epilepsy with centrotemporal spikes, or benign childhood epilepsy with centrotemporal spikes, or benign Rolandic epilepsy. The second is CELIAS, which is self-limited epilepsy with autonomic seizures, previously known as Panitopolis syndrome. Then we have the childhood occipital visual epilepsy, which was previously known as late onset occipital epilepsy of Prostott type. And the fourth is photosensitive occipital lobe epilepsy. Then we have the genetic generalized epilepsies, which include the childhood absence epilepsy, the epilepsy with eyelid myoclonia, previously known as Gibbon syndrome, and epilepsy with myoclonic absence seizures, previously known as Tassinari syndrome. Then among the developmental and epileptic encephalopathies, we have the epilepsy with myoclonic atonic seizures, previously known as DO syndrome. Lennox-Gastaut syndrome remains the same. Then we have a terminology of DE-SOAS, which is developmental and epileptic encephalopathy with spike wave activation in sleep. Then we have terminologies of FIRES, which is febrile infection-related refractory epilepsy syndrome, and HHE, which is hemiconvulsion hemiplegia epilepsy syndrome. So these are the various self-limited focal epilepsies. Within the first decade come the self-limited epilepsy with autonomic seizures and self-limited epilepsy with centrotemporal spikes. And the second decade, we have the childhood occipital visual epilepsy and the photosensitive occipital lobe epilepsy. The term benign has been removed as it fails to acknowledge the comorbidities that may be seen in a certain percentage of the individuals. Not all benign syndromes are benign. They're usually self-limited. Given the typical evolution of a disease, As they have an age-dependent remission, so the term self-limited was induced. That means that the syndrome is pharmacoresponsive and it remits by a certain age. The self-limited focal epilepsies account for 1/4 of the pediatric epilepsies. These are the criteria for the self-limited epilepsies. They should have an age-dependent occurrence, which is specific for each syndrome. The perinatal history is absolutely unremarkable. The cognition and examination of the neurological system is normal. There's a classic seizure type which is specific for the each syndrome. The EEG shows a normal background, may have a specific EEG abnormality, which is a EEG signature of that self-limited syndrome. This MRI is usually normal. It is usually pharmacoresponsive if treatment is chosen, and remission usually occurs by adolescence. So this is the first one, which is the self-limited epilepsy with centrotemporal spikes. The classical seizure types are focal seizures, which are associated with dysarthria, drooling of saliva, dysphagia. Usually these are focal seizures occurring around the orofacial region, occurring only usually during the night. The child is sleeping. These are usually seen within 1 hour of falling asleep or within 1 to 2 hours before awakening. So the nocturnal seizures with with the orofacial movements, with focal involvement, with dysarthria and dysphagia and cyalluria during the episode, points towards a self-limited epilepsy with centrotemporal spikes. EEG shows a normal background, whereas has characteristic bilateral or maybe focal centrotemporal spikes. Again, as self-limited epilepsy syndromes have usual remission by mid to late adolescence. Similarly, you have self-limited epilepsy with autonomic seizures. Again, this has nocturnal seizures in sleep, where the child has focal seizures with or without impaired awareness associated with autonomic features like vomiting, retching, pallor, meiosis, pupillary constriction. Usually, it progresses to status epilepticus in the night. These have a normal background, which have high amplitude focal or multifocal epileptiform discharges, which increase during sleep. And again, remission is by mid to late adolescence with no developmental regression. Similarly, you have criteria for childhood occipital visual epilepsy, which are focal seizures with occipital aura. That is, a child may have elementary visual phenomena like multicolored circles and usually occur predominantly when the child wakes up from sleep. EEG shows occipital spikes or spike wave discharges. Similarly, you have photosensitive occipital lobe epilepsy, where the seizures are triggered by photic stimuli like flickering sunlight. Again, it has occipital epileptiform discharges and eye closure sensitivity. These are the various genetic generalized epilepsy syndromes of childhood, starting from childhood absence epilepsy to epilepsy with eyelid myoclonia, epilepsy with myoclonic abscences. So what is genetic generalized epilepsies? These include specific syndromes of 4 types: the childhood absence epilepsy, the juvenile absence epilepsy, the juvenile myoclonic epilepsy, and epilepsy with generalized tonic-clonic seizures alone. These have polygenic inheritance without environmental factors like exposure to flickering lights, hyperventilation, sleep deprivation, alcohol. These all precipitate genetic generalized epilepsies. The development is usually normal, otherwise they're associated with behavioral complaints like ADHD, learning disabilities, and mood disorders. Seizure types can include absences, myoclonic, tonic-clonic, and myoclonic tonic-clonic seizures. EEG shows generalized spike wave or polyspike wave discharges, which may range from 2.5 to 6 Hz, which are usually activated by photic stimulation or hyperventilation. These are the childhood absence epilepsy, the juvenile absence epilepsy, the juvenile myoclonic epilepsy, and epilepsy with generalized tonic-clonic seizures alone. These are the various genetic generalized epilepsies. We also have certain DEEs like epilepsy with myoclonic atonic seizures, which was previously called as DOO syndrome. The epilepsy with eyelid myoclonia, curiously called as Gibbon syndrome. These are developmental and epileptic encephalopathies. This is the diagnostic criteria for childhood absence epilepsy. The typical seizure type is that of a typical absence seizure. EEG shows that paroxysms of 3 Hz spike in wave discharges. Whereas for juvenile absence epilepsy, the frequency of discharges is slightly on the higher side, 3 to 5.5, may have polyspike wave or spike wave discharges, and the age of onset is beyond the age of 9 to 10 years. And this is diagnostic criteria for juvenile myoclonic epilepsy, which has typical myoclonic seizures at onset, which will progress to generalized tonic-clonic seizures as well. EEG shows spike wave and polyspike wave discharges of 3 to 5.5 Hz. Then we have generalized tonic-clonic seizures alone, which may have the EEG signature of generalized epilepsy like 3 to 5.5 Hz generalized spike wave discharges or polyspike discharges with generalized tonic-clonic seizures on awakening. In epilepsy with eyelid myoclonia, the typical seizure type is eyelid myoclonia. These are worm-like movements of the eyelids when the eyes are closed. EEG shows eye closure sensitivity and intermittent photic stimulation elicits a generalized spike wave and polyspike wave discharges. In myoclonic absence seizures, the seizure type is myoclonic absence, which is a combination of myoclonic as well as absence seizures. Again, the EEG shows 3 Hz generalized spike wave pattern in time locked with the myoclonic seizures. Then we have the various developmental and epileptic encephalopathies with onset in childhood, like the myoclonic atonic seizures or DO syndrome. Here, the typical seizure type is drop attack, which is a myoclonic atonic seizures. Child has a sudden fall and immediately regains consciousness and is able to stand up again. The EEG shows 2 to 6 Hz spike wave and polyspike wave discharges, and the background is also abnormal. Second one is the Lennox-Gastaut syndrome. This is also a developmental and epileptic encephalopathy with onset in childhood. The onset is less than 18 years. It characteristically has tonic seizures and may also have other type of seizures like atypical absences, atonic, myoclonic, focal with impaired consciousness, non-convulsive status epilepticus, and epileptic spasms. EEG signature has two things. One is the slow spiking discharges less than 2.5 Hz and generalized paroxysmal fast activity in sleep. It's usually a drug-resistant epilepsy syndrome and has mild to profound intellectual disability. Then we have another term known as EE-SWAS or DEE-SWAS, which is developmental and epileptic encephalopathy or epileptic encephalopathy with spike and wave activation in sleep. These are a spectrum of condition characterized by a combination of cognitive, language, behavioral, and motor regression associated with marked spike and wave activation in sleep. That is, as the child goes into sleep, the EEG goes quite bad, the discharges get activated, and throughout the NREM sleep, throughout the slow wave sleep, the discharges are abundant. These clinically manifest as maybe as seizures, but more prominently as cognitive decline, language regression, behavioral abnormalities. So any child who's a known case of epilepsy presents to you with regression of speech or new onset behavioral abnormalities, especially cognitive decline, one should think of conversion to spike wave activation in sleep, which can be confirmed by getting a sleep EEG. If you find the discharges get more plenty during the NREM sleep, then this is established and the treatment is starting steroids. So DE-SWAS is characterized by slow spike wave abnormalities in NREM sleep, which are markedly activated during sleep. So an awake EEG may even be normal, but for these children, you should require a sleep EEG. There should be cognitive, behavioral, and motor regression or plateauing, which is related to the spike wave activation in EEG. There is usually a remission of this spike wave pattern by adolescence, although EEG remains abnormal. Most of the epilepsy syndromes can progress into spike wave activation in sleep, including the self-limited syndromes like the self-limited epilepsy with centrotemporal spikes. Hence, it is no longer caused as benign Rolandic epilepsy because even selects can lead to spike wave activation in sleep. Then we have the febrile infection-related refractory epilepsy syndrome or FIRS. The criteria is the history of fever at least 2 weeks to 24 hours preceding the onset of seizures, focal or multifocal discharges that progress to bilateral tonic-clonic seizures, seizures increase in frequency and severity progressing to super-refractory status epilepticus. EEG shows slowing of background with multifocal discharges, even having focal, electrographic, and electroclinical seizures, along with acute encephalopathy with the onset of seizures. Then we have the HHE, which is hemiconvulsion, hemiplegia, epilepsy syndrome. This is also requires a diagnosis of both acute and chronic seizures. In the acute stage, it is associated with febrile seizures, hemiclonic seizures, and followed by hemiparesis. In the chronic phase, it usually presents with occasional seizures, which are focal in onset. EEG shows slowing of background along with focal and multifocal discharges. MRI following the status shows changes in the subcortical regions and the hippocampus, whereas over time in the chronic stages, it leads to atrophy of the affected hemisphere. Is usually a drug-resistant epilepsy and has and permanent neurological damage. So there are various studies which have used these newer criteria and compared the previous 2017 with the 2022 criteria. As per them, uh, they could find molecular-based precision therapy in only 6% of the cases, and they found that applying the latest ILE classification allows comparison across settings and identifies neurodevelopment comorbidities on a larger scale, and also helps in finding a genetic etiology. This was a study from Lady Harding, which also used the ILA 222 criteria on a retrospective basis on the previous children. They found that among the children, 55% were classified into a different epilepsy syndrome by using the 2022 criteria. The 2022 criteria led to a change in the name in 77% of the cases, out of which 11% were newly classified who were previously unclassified. So the overall change in the diagnosis from the previous 2016 to 2022 was in 13.7 cases. This is in a nutshell, the previous terminology and the newer terminology. The self-limited syndromes like the self-limited neonatal epilepsy is now known, the previously known as benign familial neonatal convulsions, now known as self-limited neonatal epilepsy. The Ohtahara and early myoclonic epilepsies are now known as early infantile developmental and epileptic encephalopathy. The migratory partial seizures of infancy, MPSI, is now known as epilepsy in infancy with migrating focal seizures. West syndrome is now classified as infantile epileptic spasm syndrome. Dravet syndrome was previously known as severe myoclonic epilepsy of infancy. And the etiology-specific syndromes are a new addition to the ILA 2022 classification. Among the childhood epilepsy syndromes, Rolandic epilepsy or childhood epilepsy with centrotemporal spikes or benign childhood epilepsy with centrotemporal spikes has been renamed as self-limited epilepsy with centrotemporal spikes. Given the occasional malignant nature of the disease, it can occasionally transform into DE, SWAS, and may have other behavioral abnormalities as well. The Panitopolis syndrome or the early onset benign occipital epilepsy has been renamed as self-limited epilepsy with autonomic seizures. The late onset occipital epilepsy of Gostard type has been renamed as childhood occipital visual epilepsy. The photosensitive occipital epilepsy has retained its name. Childhood epilepsy was previously also known as childhood epilepsy. Epilepsy with eyelid myoclonia was previously known as Givan syndrome. Epilepsy with myoclonic seizures previously known as Tassinari syndrome. DOO syndrome has been renamed as epilepsy with myoclonic atonic seizures. LGS has retained its name. DE SWAS has been added. FIRES and HHE also has been added to the newer epilepsy syndrome. Thank you. Anybody has any doubts can ask in the chat box.
हेलो हेलो
हेलो, हाँ जी गौरव जी.
हाँ सर, क्वेश्चन तो है ही नहीं चैट बॉक्स में, तो आई थिंक क्लोज करते हैं आज का सेशन.
ठीक है जी. ओके.
ओके सर,
Thank,
थैंक यू सो मच.
thank
गुड
you all
नाइट.
for attending. Next week we'll come back with a newer faculty lecture. Thank you.